Hypertensive crisis. What is hypertensive crisis? In previous sessions, in previous lectures, we discussed the hypertension and management for the various cases with the hypertension and comorbid conditions. Now we will discuss about the hypertensive crisis. Hypertensive crisis is defined as diastolic blood pressure. Diastolic blood pressure, if it is more than 120 millimeter Hg, is considered as hypertensive crisis. If the diastolic, remember diastolic, it's not systolic. If the diastolic blood pressure is more than 120 millimeter of Hg. As per our previous sessions, as per the guidelines of American Heart Associations, we know that the diastolic blood pressure should be less than 90 mmHg for various chronic conditions. In hypertensive crisis, if the diastolic blood pressure is more than 1 millimeter of Hg, it is considered as hypertensive crisis. This hypertensive crisis again is classified into two subcategories: hypertensive urgency and hypertensive emergency. Urgency and emergency. As the terminologies, urgency and emergency, terminology itself indicate emergency situations and urgency situations. In hypertensive, urgency is not immediately life-threatening, and blood pressure reduction can occur more slowly over 24 to 48 hours, not immediately life-threatening. But in emergency, hypertensive emergency is a clinical situation in which blood pressure is immediately life-threatening and need to be lower to safe level within a matter of minutes to hours in order to prevent or minimize the end organ damage. It means that in emergency, there are more chances of end organ damage, and that's why we need to lower and maintain the blood pressure within minutes to hour to prevent the end organ damage. But in urgency, we can give the time up to 24 to 48 hours. How can we assess the patient in both situations? In hypertensive urgency, symptoms includes the headache, dizziness, visual changes, chest discomfort, nausea, epistaxis, fatigue, and psychomotor agitations. These are the common symptoms. But in case of the emergency, symptoms are highly variable and reflect the degree of damage to specific organ system. We can say maybe the end organ damage. The symptoms are highly specific. The possible for the hypertensive emergency, the possible presentations are recent onset severe headache, nausea, vomiting, acute onset angina, acute heart failure, and organs which affected by the hypertensive emergencies are the CNS, eyes, heart, and kidneys. These are the difference between urgency and emergency in terms of the hypertension. Let us see the comparison between emergency and urgency. In hypertensive emergencies, as we discussed, there is an the diastolic blood pressure more than 120, and in urgency also it is also diastolic blood pressure more than 120 millimeter of Hg. It is potentially life threatening, and in urgency not accurately life threatening. There are some systems are affected by hypertensive emergencies, and these are the CNS, eyes, heart, and the renal failure. But in the urgencies, the chronic end organ damage, not processing, and just maybe there are chances of the optic disc edema. Emergency require immediate blood pressure reduction within minutes to hours, but in urgency, treated for several hours to day, 24 to 48 hours. In emergency, it require IV therapy intravenous because as the name indicate, emergency, and in urgency, oral therapy will be beneficial. What are the risk factors for development of hypertensive crisis? Includes medication non-adherence. Most of the times patients are not taking proper dose of the medication at proper time. So medication adherence is one of the risk factor. If the patient is using cocaine or maybe There is and the polypharmacy. Patient is also taking another medications for some chronic condition simultaneously with the hypertensive drugs, and there may be the drug-drug interaction. Due to drug-drug interaction, there is no therapeutic effect, and maybe drug-food interaction. Some foods interact with the hypertensive drugs, antihypertensive drugs, and patient is not able to get therapeutic benefit and may leads to hypertensive crisis. Goal of the therapy. What is the goal of therapy in both the situations? The rate of blood pressure lowering must be individualized. Patients who have chronically elevated blood pressure are less likely to tolerate abrupt reduction in their blood pressure. As we discussed in the urgency, blood pressure should be lowered gradually over 24 to 48 hours. But in the emergency situations, we need it should be lowered within minutes to 1 hour. And there should be, we can say, immediate reduction in the blood pressure is required to prevent the end organ damage, and mean arterial pressure should be reduced initially by no more than 25% within 1 hour. Aggressive reduction in the blood pressure should not be useful for the patient. So mean arterial pressure should be reduced by not more than 25% within 1 hour. If it is stable, further reduction of the goal should be 160 by 100 within 2 to 6 hours, and then gradual reduction to the normal blood pressure over 8 to 24 hours. So keep in the mind, when we are treating the emergency case, within 1 hour, not more than 25% mean arterial pressure should be reduced. It means not that you have to reduce the blood pressure within 1 hour to the normal level. Not more than 25% mean arterial pressure within 1 hour. For emergency and urgency, the treatment protocols are different. For hypertensive urgency, oral medications appropriate because there is a no sign of in organ damage, and there is a no risk, and there is a no morbidity. So we have to give some time, 24 to 48 hours, and then timely follow up within 1 week after the treatment is initiated to access the benefit of the medications. For hypertensive emergency, immediate hospitalization, usually in an intensive care units, is advised, and we need here parenteral antihypertensive medications to reduce the arterial pressure, and treatment recommendations are immediate and intensive therapy takes precedence over time consuming diagnostic procedures, and the choice of drug will depend on their time course of action and most important hemodynamic and metabolic effects. Which drugs are used in the management or treatment of hypertensive urgency and emergency? Let us see first urgency. Which drugs are useful here? For hypertensive urgency, we need the oral drug, and here oral drugs we can give captopril. Captopril is angiotensin converting enzyme inhibitors, and we can say captopril is having mixed vasodilator action. Amongst the angiotensin converting enzyme inhibitors, oral, only captoprils are used because other examples from the angiotensin converting enzyme inhibitors not useful because the onset of action is too slow. Captopril, clonidine is centrally acting drugs which generally decreases the central sympathetic outflow, and it affects the alpha and beta adrenergic receptors. Labetalol is alpha plus beta blocker. Labetalol is alpha plus beta blocker. It blocks the alpha plus beta. As we know that when it blocks the alpha 1 receptor, it is responsible for the vasodilation, and this vasodilation will decreases the peripheral resistance, and beta 1 block increases the cardiac output, and this cardiac output is also, we can say, decreases the cardiac output, not increases. The blocker of the beta 1 may leads to decrease in the cardiac output and benefits in reduction in the blood pressure. So labetalol is the drug which act by decreasing the peripheral resistance, decreasing the peripheral resistance and decreasing the cardiac output both. And if it decreases peripheral resistance, cardiac output leads to decrease in the blood pressure. Minoxidil is a arterial dilator, decreases the peripheral resistance. These are the useful options for the hypertensive urgencies by oral route. All of them take several hours to adequately lower the blood pressure. And for the labetalol, there is a note: it can cause profound orthostatic hypotension, so the patient should remain in the supine position after the dose of the labetalol to prevent the orthostatic hypotension. and use of the immediate release nifedipine, which is a calcium channel blocker, capsules and other rapid acting calcium channel blockers sublingually by the bite and chew methods is not recommended. So which drug should we avoid in the hypertensive urgencies are calcium channel blocker, including nifedipine, amlodipine. Now, the drugs which are used in the management of hypertensive emergencies. Nitroprusside, which is vasodilator, phenaldopam, which is act on the D1 receptor, dopamine 1 receptor, and this dopamine 1 receptor may leads to decrease the peripheral resistance and causes nitriuresis, and IV nitroglycerin, which is an vasodilators. Nitroprusside, vasodilator, IV nitroglycerin, vasodilator. We can say nitroprusside dilates the veins and nitroglycerin also dilates the vein, decreases the peripheral resistance and thereby reduces the blood pressure. Nitroprusside or phenaldopam are preferred in patients with concomitant decompensated heart failure. If the patient has compensated heart failure with hypertensive emergency, generally the nitroprusside is preferred, which is the vasodilator, and the phenaldopam, which is act on the D1 receptor, dopamine 1 receptor. Parenteral nitroglycerins means IV nitroglycerins is most useful in patient with coronary insufficiency, ischemic heart disease, myocardial infarction, or hypertension after coronary bypass surgery. So parenteral nitroglycerin is used if the person is having or patient is having comorbid conditions of the heart. Intravenous labetalol, as we seen, the labetalol are also used by oral route in the management of hypertensive urgency, but in emergency it is used by intravenous route, may be useful in patient with the cerebrovascular diseases, as it does not significantly reduce cerebral blood flow. It not affect the cerebral blood flow, but in the labetalol for the older persons, the lower doses are required. Other parenteral therapies include enalapril, which is angiotensin converting enzyme inhibitors, and intravenous calcium channel blockers may be useful. Phentolamine, which is generally alpha adrenergic receptor blocker, is used when the hypertensive emergency is caused by pheochromocytoma, is a condition in which there is excess release of catecholamines. Hydralazine is rarely used. Hydralazine is also vasodilator, is rarely used because response is less predictable and it has long half life. Long half life, the time required to eliminate 50% of the drug is more, so the dosing will affect, its dosing will affect, and if we cannot predict the therapeutic response. And use of the intravenous potent diuretics is not useful except if the patient with comorbid conditions including volume overload or heart failure. If the patient having the heart failure or volume overload, then we can use intravenous potent diuretics. So this is all about hypertensive crisis, which includes the hypertensive urgency and hypertensive emergency. Thank you very much.